this up? It actually shows a picture, has a little bit more than mine did, so it shows a picture of what the body part may look like. Okay? So, all I did was type in burns. Okay, I just wanted to show this to you also, when I was talking before about the bottom of the feet and the hands. This is a toddler who burns his feet. Yeah, whole little thing. Try keeping that clean. Try getting that to heal. It's very, very difficult. Not that it can't be done, but just so that you know some of the things that people have to learn how to manage and that nurses have to teach them how to manage. So that's just one example. I didn't look for the no noses and the no ears, but I couldn't. But we're gonna talk in a minute about some of the different areas of the body that get burned and what it means in terms of care. But I just wanted you to have a visual of what it might look like. So that was probably after all the blisters broke, and that's what's underneath it. So that takes care of that. Nope. All right, so when we talked earlier about the two things that absolutely define how severe a burn is, one was the depth and one was the extent. So we just did the depth, that was the superficial, all that stuff. And now we're gonna talk about the extent of burns. The extent of burns is how much of the body is burned. And the rule of nines is kind of like the go-to formula for how to determine how much of the body is burned. It is an estimate. It is not, by any stretch of the imagination, definitive. It's an estimate, and I already said it's going to change over the first 72 hours as those burns continue to burn and the tissue continues to die until we get to the end at 72 hours. So the rule of nines, and I'm going to show you a picture in a minute, breaks the body up into numbers, percentages, not numbers, percentages that are either multiples or divisibles of 9. That's why it's called the rule of nines. I guess theoretically it could be called the rule of threes, but nine is it. So this is what they use when you hear on the news 30%. This is where they're getting it from. The Lund and Browder is a little tiny bit different because it takes into account the age of the person, whether it be a child or an older adult. So it's a similar system, but it's not identical. And it is more specific, but it's still an estimate. And then the ABA guidelines we'll talk about independently in a minute. Okay. So, the rule of nines. Can you see that? Yeah. Should I make it bigger or you're good? Bigger? Okay. So, you can see this is the front and the back, anterior, posterior. The anterior head and neck is 4.5. The posterior head and neck is 4.5, so all totaled it's 9, okay? But you're not gonna have always an entire face and neck burned. That's why it's an estimate, because you're gonna look at the area of the body that is burned, and you're gonna make an estimate knowing what you know about this chart. The anterior arms are 9%, so 4.5 for the top, 4.5 for the bottom, same thing for the back. The posterior trunk and the anterior trunk are both 18, so together they're 36. That's the biggest part of our body. Makes sense. Also makes sense why you would need the lunge and Browder, because that's not true in a child, correct? Yeah. In a child, that would be very, very different, and I'll show you the lunge and Browder in a minute. And then the legs and the perineum is always the 1%. Because if you add all those other things up, they come to 99, and you add the perineum, and it's at that, it's 100. So, we don't know, when they report on the news, it says 30% of their body. We don't know where that is, but they have taken estimates from where the burns are, and said, this is X percent. So if we went back to, I should have left those pictures up. Okay, let's just take this picture. Okay, that's just a tiny part of the hand, right? And we said the bottom part was 4.5, the bottom part of the arm. But that's like, I don't know. I would estimate that as probably 0.5%. Now somebody else may look at it and say, no, I think it's closer to 1%. So that's why, again, it's an estimate. It's based on judgment, it's based on learning how to do these and looking at a lot of different things. And you can't see it because it's over here, and I didn't change it. I'm talking to myself. Somebody should have said something. It's not there, Professor. It's not there. It's a tiny little piece of the hand. That would not, we don't necessarily need to give a percent for that. So just think about the rule of nines when you hear like the news and say, oh gee, I wonder what that is. 30% could be the whole trunk and back, but none of the arms and legs. That would not make sense. Unlikely. Could be. How could that have happened? Somebody had water thrown at them that was hot, front and back. Okay. And the other thing, when we're looking at estimating and looking at the body, you must always make sure that the story matches what you're seeing, because burns are often used as abuse. So, and this is especially true of children. Okay? So if you work in an emergency room and the mother comes in and says, the baby got burned in the bathtub, but that baby has burns on their chest and their shoulders, how likely is it that that baby got burned in the bathtub? When you get a baby burned in a bathtub, and it happens, I'm not saying every time it happens it's abuse, but what do we all do? When you stick your foot in a tub and it's hot water, the first thing you do is get your foot out, right? Babies, when they're being dumped into water, the first thing they do is pull their legs up and scream, and what gets burned is their buttock, the scrotum or the vagina, and the back of the legs. That's what gets burned first. So the story that people tell you should match what you're seeing. And it's not just children. When, again, that community student experience that I had, we saw a guy, and we couldn't figure, again, we knew nothing. We were being very good. We did his assessment. We took off his little t-shirt. We took off his shirt, his sweater, his shirt, his t-shirt. You know, the old people that have 5,000 things on. And we got him down to his skin, and on his back, he had, the only way I can describe it is like dark pigmentation in rows across his back. And we asked him, we were like, well, do you know that your back looks like that? Oh, yeah. Do you know what it's from? No, it's been like that a long time. He was in his 80s. And so we wrote it down, and then when we went back the next week, they had arrested the son for elder abuse. He had been punishing his father by putting him, it was an old building in the city that had those big old radiators. And it was in a house, it was his house, he owned a house. And he was putting him against the radiator and burning him. But because the other nurses, and this wasn't their fault, were going there for a foot wound, they had never undressed him. But being students, we were told, do a full assessment. So there we were, taking off all the man's clothes, and nobody had ever seen it. He had been burning him for years. Years. This poor little man, and he was totally dependent on the son for his shopping, for his cooking. The son lived with him. He lived in the house with his abuser. Horrible. We were horrified. I'm still horrified when I think about it. So sometimes you need to investigate. We didn't know to investigate. What did we know? He had marks on his back. But fortunately, when we wrote it in our note, somebody read that and they were like, what is that about? So they went back to the house the same week, which they never do. They only go for one visit a week. And when they went back, they did make him undress and they saw it, and then they spoke to the son and they talked to the father, and the guy ended up getting arrested for elder abuse. And the father cried. Because now he had to leave his home. Because the only way he could stay in his home was if he had somebody to help him take care of himself. So it was a terrible situation all the way around, but you have to be careful because we all know about the stories about the cigarette burns and, adults and children. So just to be careful about it. So this is rule of nines. I just want to show you the London Browder and show you how different it is. Because it's not very. See if we can find one that we can read. Maybe this one. Okay. So all right, so this is the London Browder chart. The numbers are different. And then if you look down here at the bottom, they have A, which is the head, and then they have ages 0, 1, 5, 10, 15 adults. So it's broken up based on age, specifically for the head and the legs, because those are the things that are most different in a child. And you can see that they use totally different numbers. They have, 2 for the top. They do 1.5 for the arm, 1.5 for the lower arm, and then 1.5 for the hand. So that picture that I showed you of the hand, where I said 0.5%, it's probably pretty close. Because if a whole hand is 1.5 on one side, that was just one little area of it. So just be aware that there are 2 different methods. Most frequently used is the rule of nines. But this is perfectly legitimate and okay to use. And probably should be used for a child. All right. Now, the ABA guidelines of the American Burn Association. And these are strictly guidelines. Hospitals and physicians do not have to follow them. Then why do they do them? Well, they do them because they would like it put out there, and they keep hoping that more and more people will adopt it. But the reality is, because healthcare is a business, and a lot of these recommendations are that the patient be transferred to a certified burn center. That means losing income and losing, can't remember, but the hospital would lose income if they transferred every single patient out that had a burn that required a burn center, because there are many. They're pretty wide about who the American Burn Center believes should be at a burn center. That being said, if you're taking care of a patient and you're not at a burn center, and you feel like they're not getting the care that may be optimal for them, you can approach a physician and say, I'm going to call, where's the burn center in New Jersey, anyone know? Northern New Jersey.
Is it, oh no, I don't.
St. Barnabas. St. Barnabas in Morristown is the only certified burn center in northern New Jersey. In southern New Jersey, it's Cooper University Medical Center in Camden. And then we have Cornell in New York, but they're not really transferring over to New York. But you can say, I'm gonna call the nurses at St. Barnabas because these wounds don't seem to be healing. And maybe they have a trick that we don't know about, okay? And you kind of do a nurse-to-nurse consultation, and you call the unit and you say, look, I'm a nurse, I work at, I don't know, whatever hospital you work at, and I've got this patient, and do you have any thoughts for me? Do you have an article I can read that might help me? Because they may not feel comfortable giving you medical advice over the phone. You could be Joe Schmo for all they know. But do you have an article that I could use to show a physician what we could be doing for this patient because it's been X number of weeks and they're not healing? Or you could just go on the internet yourself and look for articles for current practice in burn care. Because even though emergency trauma physicians are supposed to be able to take care of every emergency and trauma, it's a specialty. Burn care is a specialty, and they don't always know everything. And some of them are better than others anyway. So, anyway, onward with the American Bar Association guidelines, which I will actually read so I don't screw them up. The guideline is that anything greater than 10% body surface area and the patient has to be a child or older than 40. All those people should go to the burn center. So, over 40, childhood as defined by up through 15, 16, like late adolescence, and 10% or greater total body surface area burned should be sent to a burn center. So that basically leaves 17 to 39-year-olds with teeny weeny burns. If the hands, the feet, the face, the eyes, the ears, or the perineum are burned, they should go to a burn unit. So that little baby that toddler that we saw should have been in a burn unit. I don't know if they were, I didn't read. If there is an inhalation injury, they should go to a burn unit. If it's an electrical injury, they should go to a burn unit. And if if there are any other extenuating circumstances, such as the patient is defined as a major trauma with the burn, if they have concomitant illnesses like COPD or diabetes or one of those good things, or if there are fractures, they should go to a burn unit. So basically, everything except burning your hand on the stove should go to a burn unit. That's what they would like. Now, does that happen? Of course not. They take care of burns at Valley, they take care of them at Chilton, they take care of them at Pascack Valley, they take care of them at Urgy Centers, they take care of them all over. But these are guidelines that they would like us to, not us particularly, but in general, the healthcare, to follow. Because they firmly believe that patients will receive optimal care if they are in a unit that is designed specifically for them. And I don't know about you, but if I were burned, I would want to be in a place where I knew that they knew exactly what to do for me. Thank you very much. You know, we had a patient a couple of years ago on the floor that I take my students to. She had dropped a hot pot of soup, the whole front of her legs from above her knees to her feet, and then she had stepped in it, so her feet looked like that little baby's feet, and in between her toes looked like that little baby's feet. And she was there, we got there it was January, I will never forget it. We got there in January, she had already been there, but she wasn't there when we left for Christmas. So somewhere between Christmas and when we went back in January, she was admitted, and she was still there when we left in May. And she was not anywhere close to being discharged, and she had 3 small children at home. They could not get these feet to heal, because every time they healed a little bit, she'd feel better, she would hop out of bed, and they'd open again. It was a nightmare. It was a nightmare for her, it was a nightmare for the kids, it was a nightmare for the nurses. She should have been at St. Barnabas, she should have been, even if they wanted to first try to treat her, but somewhere in 15 weeks, somebody should have said, this is not working. And maybe we need to transfer her to someplace and they have some tricks up their sleeve that can help us with this. So it was horrible to watch. It was just really, really horrible. So anyway, those are the extent of the burns and the guidelines. And this is just an informational slide. This is what we'll be talking about when we come back tomorrow. So just quickly, pre-hospital is when they're at wherever they are at the event that caused the burn. So things are going to happen in the pre-hospital stage, then things are gonna happen in the emergency room, and again, we're talking about big burns, we're not talking about burning your hand on the stove. Then, there are gonna be certain things that occur in the ER. There is something that we call fluid resuscitation. Fluid resuscitation occurs within the first 48 to 72 hours, where the fluid needs to be replaced because the fluid is moving out of the vasculature and into the body. And then we'll talk about the different medications that are used during the different stages. I do want to get to the next slide. Which is not the best slide, but hopefully it'll make sense in a minute. This is any and all possible laboratory data that you could want to get on your patient. And there were too many repeats on things that get done in multiple stages, so it was just easier to put them all on one slide, and then I'll tell you when they get done. Okay? So cultures and sensitivities are going to be done during the acute and the rehab phase of treatment. It'll all make sense tomorrow, I promise. BUN and creatinine are going to be done baseline in the emergency room, and then as needed throughout the patient's stay. So that would be the emergent resuscitative stage, the acute stage, and part of the rehab phase. And the same for the potassium, the sodium, the blood sugar, the hemoglobin and hematocrit, and the white cell. The UA will also be done on admission, I forgot that one, and then as needed throughout the course of the patient's stay. CPK is going to primarily be done with electrical injuries. Although it can be done with very large burns that are going into a lot of different musculature. Because what does CPK measure? It measures the protein that gets released when there's muscle damage, right? And I said to you that burns will continue to advance for over a 72-hour period. So even though we almost always think of CPK as a cardiac thing, which is why we absolutely do them with electrical injuries, because we can't always tell where and what the damage is, because it's internal from entry point to exit point. So if you watch the CPKs, it can give you an idea of how much muscle damage there is. So they will always do them with electrical injuries. They may do them, again, with larger surface injuries if they believe a lot of muscle has been damaged, and they're watching to see when the damage actually stops progressing, because it'll be lower on day 1 than it is on day 3. Okay? But that's not always, but almost always in electrical. Nutritional indicators should be drawn when they come into the ER, but they're not looked at again until the end of the acute phase and the beginning of the rehab phase. Because we're really not too worried about their nutrition immediately. So the end of the acute phase or the beginning of the rehab phase. Because really what we're trying to do during the emergent resuscitative and the beginning part of the acute stage is to keep them alive. And we really don't care too much about what they're eating. We need to know from the beginning what their nutritional status is so that we know what's coming down the pike. Because if you've got squatters sitting in a building that burns down, and they're squatters that have been drinking more of their calories than eating them, and their nutritional status is in the toilet to start with, then they're gonna need a lot more support once they pull through that initial time period where we're trying to keep them alive first. If you have somebody who's got uncontrolled Crohn's disease and their nutrition is not that great, same thing. You know, I don't mean to sound judgmental that we're just talking about the guys that are squatting in a house. But whoever is at nutritionally, you have an oncology patient that ends up in a house fire, disaster. Nutritionally, they're already starting at a deficit, but we're not gonna really act on it until later on. And the type and cross is also done in the emergency room. That's only done once. And even though we still call it a type and cross, we don't actually cross-match the blood anymore until the patient needs the blood. So really, it's a type and hold, but they still call it a type and cross. But I want you to understand that we type the patient, and then we hold, it's just sitting there waiting. And then once we decide, yep, their hemoglobin is low enough, we need to give them some blood, then they'll cross-match it to whatever blood they have in the blood bank to see which one works for them. Because once they cross-match it to a patient, they cannot use it for another patient, and it would need to be thrown out. So that's why we no longer type and cross everybody when they come in. We type them and then we hold it and we cross-match them when they need it. Because the cross-matching is very specific to that patient. But hopefully there'll always be blood available if they need it. And we'll talk about each of these as we go through the stages. Nope, wrong place, here we go. Okay, so diagnostically, and then we'll finish. Here we go. Diagnostically, especially if there's an inhalation injury, we're gonna be looking at ABGs and pulse oxes. We want to do a chest x-ray to see what's going on in the lungs. They will do an EKG or an ECG, whichever you prefer. Ventilation perfusion scans are going to be done later on in the process, either during the acute or the rehab phase, as well as pulmonary functions, same thing, late acute or rehab phase. The bronchoscopies, however, may be done immediately. And they are done immediately when there is evidence that there is an inhalation injury. Because, why? Swallowing and what else? Airway. So if it looks like they and what would be some signs that someone may have an airway injury? Their voice can get hoarse. My voice is hoarse, but I don't have an airway. Their voice can be hoarse, they can have coughing. But even before that happens, anything you can think of?
If you're doing a focused hands exam, when you do like your visual inspection, you back and they have like soot, some of that, if it's a burn.
Sometimes it'll be soot and burns, yes. In their mouth. What else might happen? Shortness of breath. If any of these little hairs, eyebrows, eyelashes, lips are burned, there's a good possibility that the heat was close enough to cause an inhalation injury. And you should look in their mouth for soot, and you should also look in their mouth and in their nose for blisters. But singeing, that's called singeing, when these little hairs are all, crisped. Or your eyebrows or your eyelashes. That's always a very good indication that the patient is going to have an airway problem. And the other time would be if it was an explosion. Because anytime there's an explosion, the force of that explosion forces all the hot air down, up your nose, down your throat. So you can get burned from that. So if a patient is in an explosion, they will oftentimes do a bronchoscopy early, because they wanna see what damage there is in the lungs right now, right this minute. And they may prophylactically intubate the patient, rather than wait until the swelling gets big enough that it's gonna cut off the airway, and then they have to trach the patient emergently. So rather than do that, if they've got signs and symptoms that indicate there was an inhalation injury or could be, they will intubate the patient. First they'll do the bronchoscopy to look what the lungs look like, and then they will intubate. And if they're wrong, they'll take it out. But that's the plan on the flexible bronchoscopy. Okay, so we're gonna end there, because we're over. It's been a long day, we'll study, all right, go home and take a rest.